So good evening, everybody. I hope you listen to me and you hear me. So I'm Raphael Ervings. I'm the director BVI Western Europe, and I'm really honored and happy to invite Dr. Rafa Bilbao, who will present you today his clinical experience with the ISOPURE lens. But before speaking about his clinical experience, he will of course introduce the technology. So Dr. Bilbao is one of the doctor leader of the Clínica Baviera based in Spain, the largest private clinic in Spain, and for sure one of the largest in Europe, and actually now part of big group also including China. So major refractive center, and Dr. Bilbao is mainly focused on cataract, lenses, and refractive surgery. So now the podium is yours, Dr. Bilbao. Bilbao, you can start. So after the talk of Dr. Bilbao, we leave at least 20 to 30 minutes for question and answer. So you probably know how to ask the question. So you have a button question answer below on your screen. So you can for sure ask the question. And at the end of the presentation, I will try to summarize this question and we will hopefully be able to answer all of your questions. Thank you.
Okay, thank you. Thank you very much, Raphael. Thank you very much, BVI Physiol, for the invitation to this webinar. Thank you to all the assistants at this meeting. I would like to briefly present you my experience after virtually 2 years with the ISOPURE lens, and before that I will briefly also introduce the optical principles of this lens. I'm going to share the screen with you right now. Here we are. Can you see the presentation?
Perfect.
Okay, so here we are. These are my financial disclosure. First of all, I have no financial interest in any of the products mentioned, although I am a scientific consultant for Physiol. First of all, I would like to acknowledge my optometrist team, especially Victor Tejerina, which helped me a lot during the design and the performance of the study I'm going to present you today. As you all know, in 2021, nowadays, trifocal diffractive lenses are the gold standard for presbyopia correction. However, they have some limitations regarding anatomic contraindications from the patient, undesirable visual effects for these patients that are sometimes unacceptable and others not recommended for certain professional or hobby activities. And besides that, they often present logistic or economic limitations for its implementation. And this is why around 6 or 7 years ago, Adolf Lenses were launched in the market. As you all may know, the Adolf lens term is a term that is very confusing and very controversial, as the first called Adolf lens is really just a low-art bifocal diffractive lens. As you all know, diffractive and refractive optic generates more than one single focus, and whereas real Adolf lenses, if we use it in the sensu strictus of the term, they should manage to elongate the focus of the distance vision towards the intermediate vision instead of splitting the image. The extended focus should obviate the overlapping of the distance and near images that are typical of the multifocal lenses, and eliminating, among other things, the halo effect. However, the problem is by elongating the focus, the quality of the vision is sometimes lost in the retinal image, and its degradation in visual quality is what limits the performance of these lenses. In 2014, initially the FDA, later the American Academy of Ophthalmology, and more recently the ANSI, define Adolf lenses, but just by their functional outcomes criteria. All these organizations lack to consider the mechanism of action and thereby the visual secondary effects that these lenses may produce in the vision of the patient. And thereafter, there are many different types of classification of so-called Adolf lenses. It is often confusing for a surgeon who's initiating in this type of lenses. And these lenses often show completely different optical strategies, and thereafter completely different optical and clinical performances. This is a personal classification of the optical strategies related to the so-called Adolf lenses. There are up to now 5 different types of optical strategies: low addition diffractive optics, low addition refractive zonal lenses, that should be better called hybrid multifocal Adolf lenses, and what we'd better call real true Adolf lenses are lenses that extend the depth of focus with a small aperture optic, with an in-depth optical device such as an Axicon in the center of the lens, or lenses with a modification in the spherical aberration. In this group is where the ISOPURE lens is included, and these lenses work through the modification of the spherical aberration of the lens. The ISOPURE lens features a modification in the spherical aberration across the full optic, anterior and the posterior surface of the lens, that gets to extend the focus, however, or no matter what is the pupil size of the patient and the lighting condition. As you all know, all these lenses or all these spherical aberration working lenses should get a balance between the increase in the depth of focus and the contrast sensitivity of the image. Because if you extend too much the depth of focus, you can lose some quality of the image. And this is something that ISOPURE lens has got to a very good balance, getting very, very nice results in the optic quality of the image. The ISOPURE optic features a polynomial complex surface design across the full optic that displays a centripetal progressively increasing dioptric map that extends the depth of focus in comparison to the monofocal predecessor. This blue line here is the depth of focus obtained with the monofocal predecessor lens, and this is the extension obtained with this modification of the dioptric map in the lens of the ISOPURE lens. ISOPURE, besides, was customized to provide a more negative spherical aberration in higher dioptric powers that are usually used in hyperopic patients. And hyperopic patients usually have more cornea with more positive spherical aberration, and this increase in the negative spherical aberration of the higher dioptric power lenses compensate for this higher positive spherical aberration of these hyperopic eyes. Regarding the optical bench measurement that were performed in Belgium in 2018 and 2019, beginning of 2018, we can see that the models were used with the ISO 1 and the ISO 2 corneal models, including the effect of the cornea, of the model cornea in the ISO 2, and without this, the effect of the cornea in the ISO 1 models. And they obtain and they described an extension of the depth of focus compared to the monofocal predecessor with the ISO 2, which is a more physiological optical bench model. And the quality of the vision, the quality of the image was maintained virtually unchanged, but the depth of focus compared to the monofocal predecessor was increased up to near 50%. In this previous study by Dr. Studulka presented in the ACRS Congress, there is a clear extension of the depth of field in the defocus curve. And regarding the extension of the focus compared to the pupil size, we can see, although the extension of the focus is higher as expected with a smaller pupil, and this is related to the stenopeic effect of a smaller pupil, we still maintain a higher depth of field, depth of focus compared to the monofocal predecessor, even with larger pupils. And this is a difference compared to other lenses that plays with the aberration with a negative spherical aberration in the lens, such as the eye hands. The ISOPURE maintains an extension of the depth of field, no matter what is the pupil size of the patient in each situation. In this ISO 1 model, in the USAF resolution targets, we can see how in the distance the image obtained without the effect of the cornea of the patient is very similar with the ISOPURE and the monofocal predecessor lens, and in the intermediate vision, whereas the monofocal shows the degradation of the image, this image is better maintained with the ISOPURE, as it offers a continuous visual field between the far and the intermediate vision. What is another advantage of the ISOPURE lens? Well, the lens is a hydrophobic, acrylic hydrophobic lens that is based on a glistening-free material that was designed and launched by Physiol a few years ago, and that has been published, is virtually glistening-free. And we had previously a large and extensive experience with the monofocal predecessor, with the micro F platform, which in my personal experience and our personal experience in Madrid is an excellent platform, glistening free with a micropure, with the predecessor aspheric monofocal lens, with which we have obtained previously an excellent results regarding the vision, the refractive outcomes, anatomics, stability in the bag, and TCO rates after 3 years and over 7,000 implants in Clínica Baviera. So in summary, this lens was presented to me as a preloaded hydrophobic lens with glistening free, with non-diffractive or zonal refractive profile. Thereafter, there is no loss of energy, and as easy to manage with the patient as a monofocal lens. And this is why we decided in the summer of 2019 to start a pilot study that we perform in Madrid with patients with cataract eyes, no clear lens refractive extractions. Patients were implanted monocularly or binocularly with ISOPURE. Patients had no other ophthalmic problems and a corneal cylinder below 1.5 diopter. When the patients were implanted monocularly, they were targeted for emetropia. When they were implanted binocularly, one of the eyes for emetropia, the other eye for a small amount of myopia, to increase the depth of field binocularly. This is a short video clip of the first patient that was implanted in July 2019. She was a lady around 80 years of age with a dense nuclear cataract. As you can see now, we can discuss it later. The implantation of the lens, of the preloaded lens, is a very, very friendly. It's a very friendly injector system, and the lens enters very, very smoothly into the bag, and it's very easily positioned. In fact, I can tell you that I'm hydro implanting many of the patients I'm doing with this platform that is extremely friendly, okay, and very, very stable in the bag. This is the end of the surgery, starting the irrigation aspiration after the implantation of the OVD. No. These are the pictures of this lady 1 month after the surgery. And we included in the pilot study the 37 first eyes from 22 patients that were implanted monocularly or binocularly, and they were evaluated for 6 months of follow-up. Sorry about that. The epidemiological results are the typical for a cataract population. The age is around 70 years old, and as I mentioned before, there was no cylinder induction with this patient. The preoperative spherical equivalent is slightly myopic. The postoperative, as expected, is slightly myopic also. Regarding visual acuities in these patients, this is a summary, a table summary. Regarding the distance visual acuity, uncorrected is around 0.85, 0.9, and corrected between 1 and 0.95. intermediate visual acuity at 80 centimeters, which is what we use with the computer, is in the surroundings of 0.6, 0.65. And at 66 centimeters, which is what we use normally for the tablet, is around monocularly 0.55, 0.6. Monocular, these are monocular visual results. To notice that even near visual acuity around 40 centimeters is quite positive, is around 2055, 2040. In summary, this is what is probably the most important. In the distance, we obtain very good distance results with visual acuities binocularly and monocularly around 2020, and monocular intermediate visual acuity around 0.7, 2032, and binocular around 0.75. And the binocular near vision is 2040, which allows many patients not to use near glasses for certain short time near visual activities. Regarding the defocus curve, this is the mean defocus curve in a continuous line monocular, in dots to binocular. As you can see, there is an extension compared to a monofocal classic aspheric lens, obtaining a vision that is equal or better to 0.2 logmer monocularly between the distance and 77 centimeters, and binocularly between the distance and 62 centimeters. The result obtained by Dr. Stodulka in its previous study was even slightly better than these results. And regarding contrast sensitivity, our patients show results monocularly and binocularly in photopic conditions and mesopic conditions that were within the limits for this age group. We also perform 2 questionnaires regarding quality of life and quality of vision. And regarding the quality of vision, we perform these questions in this validated questionnaire. And the results show that regarding these 2 questions included in this NIIRQL 42 questionnaire, that 90% of patients show no halos or glare, never, and only 1 out of 10, around 9%, presented halos or glare, but not often and not bothersome at all. Regarding the quality of life and among these questions regarding glasses independence, we perform this questionnaire, validated questionnaire, and 90% of patients do not need glasses on the distance or for intermediate vision. And half of the patients were able to function comfortably without glasses at near vision very often. This doesn't mean patients are not going to need glasses for the near vision or for reading, but they are free of spectacles for most of the activities in which using glasses for near are very uncomfortable. They can work comfortably, and only using low prescription near glasses for certain deep or prolonged or extended time activities for near and also sometimes for intermediate vision. What does ISOPURE lens provide our patients against classic monofocal lens? The extension of the single focal point from distance to intermediate vision, in our experience, can be enhanced with a certain mini monovision strategy when patients are implanted binocularly. But patients are also implanted in one eye if they had had surgery before with a classic monofocal lens, and they feel the difference between the intermediate vision with one type of lens and the other. This lens has not the negative effects and contraindication that monovision has when we implant classic aspheric monofocal lenses. In our practice, we tend to do monovision if we can do it in patients who have good binocularity and have good stereopsis. But these lenses show the advantage of not having the contraindication of monovision. And the focus extension ranges from 0.5 to 1.5, depending on the patients and the amount of small myopia left in one of the eyes, and this allows us to widen the defocus curves, and we obtain a better tolerance to residual anisometropia. And these allow us to obtain greater glasses or spectacle independence that make virtually unnecessary the use of glasses for intermediate vision, and a lower addition and less needed for near vision. What can the patient expect? What do I say to the patient before implanting this lens compared to a monofocal lens? They'll be able to drive without the starbos or halos that are of a multifocal lens. They'll be able to see TV subtitles when they're watching the TV or the cinema, and they will have a better and a useful uncorrected intermediate vision that will allow them to see, to walk better on uneven surfaces, to see the dashboard when they're driving and having a good distance vision, or when they're using the computer or the table. They'll be able to play cards, to play music instrument, to cook or eat, or to see briefly a ticket price or browse the newspaper without the need of glasses. And they also obtain, compared to the classic aspheric monofocal lenses, a better near vision. And this improvement is variable regarding the patients, and the glasses needed afterwards ranges between, in my experience, between 1.25 and 1.5 instead of the 2.5 that usually is prescribed for these patients if they had been implanted with a classic monofocal lens. What does ISOPURE bring us or give us compared to the diffractive or zonal refractive multifocal or so-called hybrid Adolf lenses? This ISOPURE lens shows no division of light or no loss of light. There is no significant reduction in contrast sensitivity. These lenses don't present these photopic phenomena such as halos, glares, or starboard. And the lens influence, the lens performance is less influenced by certain medical factors of the patient, such as having a slightly worse or worse surface quality, if there isn't a perfect corneal regularity, if the lens is not perfectly centrated, or if there is a relatively worse macular optic nerve status. This ISOPURE lens works better than a diffractive or a refractive multifocal lens because it tolerates better this not severe disease in the eye of the patient that sometimes are contraindication for the use of multifocal lens. It also provides us simplicity in the patient management, and this is, for me, it's very important because we spend a lot of time, especially in the preoperative assessment and explanation of the surgery in the patient. We have to do it personally in the clinic where I work, and these lenses present less fewer patient medical contraindication, fewer professional contraindication, fewer psychological contraindication for the patients who are very type A personality or very exigent regarding the quality of the vision can be implanted with these lenses without fear of how they're going to react after a multifocal implant. And they're also less demanding for the preoperative technology we need for premium multifocal lenses. And as I mentioned before, these lenses need less time to explain to the patient how their vision is going to be. But don't remember that these lenses also are going to obtain less spectacle independence, and with the gold standard nowadays for presbyopia correction, which are trifocal lenses. The ideal candidate for ISOPURE implant, in my experience, are patients with an active profile, lightning conditions, not willing to accept the visual disturbances related to multifocality, not being bothered by wearing reading glasses, and with having a high probability of a minor residual refractive error. I think these lenses are suitable for routine cataract surgery for most of our patients. And what are the clinical guidelines I would suggest for someone who would start using this type of implants? the refractive target of these lenses should be emetropia in both eyes, or in my personal experience, better emetropia in one eye and a slight minimal 0.5 myopia in one eye. Astigmatism up to now is a problem, and I'm a surgeon that I prefer using slightly larger incisions around 275 because I can play with the astigmatism, doing the incision through the steepest meridian, and I can correct up to 1 or 125 diopters of corneal astigmatism. But astigmatism is a concern, and patients should try to have less than 0.75 or 1 diopter of residual cylinder after the surgery. Patients with high preoperative negative spherical aberrations, such as patients with a prolate corneas with keratoconus or keratoconus suspect, or patients who had been previously treated for presbyLASIK or hyperopic LASIK or PRK, in my experience, present a high negative spherical aberration in the corneas and shouldn't be good candidates for these types of implants. And patients with severe maculopathy, severe optic neuropathies, or severe corneal diseases really would not obtain the beneficial effect of these slightly more complex lens than a classic aspheric monofocal lens. So in these cases, there shouldn't be any difference in implanting an aspheric classic monofocal lens. In conclusion, the new ISOPURE lens seems to provide a very good distance vision quality combined with a visual improvement in intermediate vision by accentuating the EDOF effect without inducing photic effects. And compared to the monofocal predecessor, we have obtained similar distance vision, similar photopic and mesopic contrast sensitivity curves, with a clear improvement in the defocus curve and a better tolerance to residual ametropia. A mini monovision strategy, leaving 0.5 in one of the eyes, improve the binocular intermediate vision. Improves the binocular intermediate vision without modifying the binocular distance and near vision. And we have obtained a very good level of patient satisfaction with a very reasonable spectacle independence with the use of these lenses. We need further study, and we have already implanted over 150 lenses, I guess, but we need further studies to confirm these initial promising results and the positive inputs from these patients, to directly compare the outcomes of this lens with the monofocal predecessor, and to investigate the clinical performance of the lens in relation with some items that I consider important. The physiologic changes in the pupil size. This may explain why some patients get better intermediate and near vision than others, with the changes in the pupil centration compared to the lens, with the different dioptic powers of the lens, and in scotopic conditions. This lens could be, as I mentioned before, very possibly used in some ocular conditions considered contraindication for multifocal lenses, and this is very, very important. And I would address this lens better as a monofocal plus lens with an extended focus, that is, extends the uncorrected depth of focus, improving the spectacle independence. And this is what I would like to share with you. Thank you very much. And we are open if you want to make any question or if you have any comments that you would like to do.
Thank you, Dr. Bilbao, for this great presentation. I believe it was interesting to understand a bit more the technology and also your clinical experience. So as I mentioned during the introduction, you have the possibility now to ask a question through the bottom question and answer on your screen, or eventually through the part called discussion. So we have now 30 minutes for question and answer. Let's start potentially with the first one. So if I want to start as a surgeon with this ISOPURE lens, which kind of patient do you recommend to start with? Hyperope patient or potential myope patients?
I don't think there's a great difference, to be honest with you. I would definitely start with patient with cataract, as I would start with any other monofocal lens. Honestly, for the first patients, I don't think there's a big difference comparing. Usually, from the refractive point of view, hyperopic patients are more usually more
easier,
happy, yes, yeah, after the surgery, because they improve in the distance and in the near, whereas myopic patients often feel they have lost some of their near vision, especially if the cataract is not too deep. So yes, possibly hyperopic is better to start, but my first patient was not a hyperopic patient, and she was extremely happy. It was a dense cataract. I think any patient with cataract, if it's hyperopic, is likely better, probably, yes.
Okay. Next question. So you spoke about astigmatism and the importance to treat the astigmatism and potentially having at the end of the surgery residual 0.75 or 1 diopter maximum astigmatism. The question is if there is a toric IOL version of this ISOPURE at the moment on this platform.
I would like there would be one very soon, and this is something I'm please asking physio to do their best. I know there's something going on, and probably in the near future something will be, but definitely would be of a great help, yes, in the decision, because yes, management of astigmatism in nowadays cataract surgery is a very important issue, and toric lenses would be a major advantage, yes, for many patients.
Yeah, and if I may, Dr. Bilbao, complete your answer. I would say that, of course, BVI is working on a toric version, but not based on this platform, because when this platform is great in terms of refractive stability, the rotational stability is not optimal with this closed loop. So, of course, we are working, but on the version on a double C-loop that we created years ago to be able to have an optimized toric version. Right, thank you. Another question: have you tried more difference in refractive outcome between eyes, emetropia and -1, for instance?
I think it's better not to leave more than 0.5. Why is that? Because in the distance, these patients see virtually like a monofocal lens, but not exactly as a monofocal aspheric lens, because as I mentioned in the study, there is a balance between the depth of focus and the quality of the vision. If you leave more than 0.5 diopters, my experience is patients are not as happy in their distance vision. So I think leaving up to 0.5, 0.75 maximum in the non-distant eye would be fair enough. And in my experience, I have patients with -1, and they're happier if this refractive final outcome is lower than 0.75 diopters. So better no more than 0.75.
Okay, thank you. Another question. So you share with us so your experience in your clinical investigation about 22 patients, which is good, but not a big number. So can you share with us potentially your extended experience since the end of the study until now with this IOL?
Yes, one of the things I really like with this patient, with this lens, is I have had no surprises, and this is something extraordinary in my practice, because as I mentioned to you, we spend a lot of time explaining to the patient with the multifocal lenses, and although I restrict a lot the criteria to implant these lenses, ISOPURE lens is a very straightforward with no surprises. It's a very predictable lens. So up to now, I have not had any disappointed patients. I only pay special attention to the previous corneal spheric aberration, and I try to avoid its use in, I would say, in any cornea that would have any negative value for the corneal preoperative spherical aberration. But on the other side, I have like 4 or 5 patients already implanted with previous myopic treatments, in which the use of a trifocal lens is not completely perfect decision, and or patients were not willing to have the visual discomfort of the diffractive lens, and these patients work extremely well. I think the combination of a corneal positive spherical aberration with this lens of a negative spherical aberration, this combination, I cannot tell you, I'm not a physician, a physic or an optometrist expert on corneal aberration or on optical aberration, higher order aberrations, but the combination of a cornea with a positive spheric aberration and a lens with a high negative spheric aberration makes the patient to be very happy and to have a large extension of the focus, and these patients are very happy. So previous myopic patients are good candidates for the use of this lens.
Okay, excellent, thank you. The other question, would you recommend this lens for RLE patient or only for cataract patients?
We started with cataract patients. I'm doing it now systematically for patients with RLI, refractive lens exchange. In this case, coming back to your first question, Rafael, I would limit the use more to patients who are hyperopic, because myopic patients, of course, we have to be careful with all of them, but for different reasons. But one of them is a good vision they have prior to the operation in the near vision. So I have used it. I use it in refractive lens exchange in hyperopic patients with very good results. I have implanted, I can remember recently 4 or 5 patients and that are very, very happy, basically because they have an excellent distance vision, no fear to have this photopic phenomena, loss of contrast sensitivity in certain patients who are professional driving professionals or patients who are very delicate or very exigent with the quality of the vision they need. It's a good option. And in our practice, and another issue in our practice is here in Spain, we have a national health system that works very well. Hospitals in Madrid area work very well. They implant classic aspheric monofocal lens, and this lens for us is also a plus, an addition that we can give to our patients compared to what it is offered right now in the NHS. So it's another aspect, it's another advantage for us that we can offer to our patients compared to what they would get at the NHS for free. Yes.
Okay, thank you. Another question, and I suppose this is for second operation, I mean the second eye. So can you implant ISOPURE in the second eye along with another type of monofocal non-Adolf in the first operated eye?
Yes, as I mentioned in my talk, I have done it in the pilot study and later in other patients, and patients notice the difference is that if you leave them emmetropic, they will tell you they have not a different distance vision, but a better intermediate vision with the eye implanted with the ISOPURE compared to a classic aspheric monofocal lens. Yes, I don't like in my refractive practice, I don't like doing mix and match of different optical technologies. Usually if I go for a trifocal, I like using a trifocal lens in both eyes. If I do a bifocal diffractive, the same. If I implant a zonal refractive lens, I do it in both eyes. But I don't mix and match different optical technologies, but an ISOPURE and a classic aspheric monofocal lens is not a different optical strategy. So you can mix and match, yes.
Okay, thank you. So next question, probably from a surgeon. So facing many issues with different preloaded system in the world. So asking about your experience with this specific preloaded system.
Nowadays, I am very happy. I went through thorough discussions with Christophe Pagnol, which is one of the I don't know, well, you probably know it better, Rafael. It's one of
R&D director, yeah.
Yes, he's one of the persons who developed the injection system, and it's one of the preloaded systems that I like most, really. But A very important issue is when you start implanting this lens, please follow very strictly all the tricks that are given by the physical specialist, because if not, you're going to have some problems. The lens should be slightly heated before the operation. So it's a hydrophobic lens. They are more rigid compared to hydrophilic lenses, and a slight increase in the temperature, especially if the lenses are stored in cool rooms, is better. And then the nurse or whoever is loading the system should very carefully follow all the instructions. If this is done like this, and a good trick would be, don't load the lens until very, very shortly before the implantation. I asked the nurse not to do it just when I finish the irrigation aspiration. So it's better to wait 20 seconds or 15 seconds, which is what you last, than doing it previously and leaving the lens like this for a long time. So, and use a bit of OVD before the implantation, because as a hydrophobic lens, I think the risk that the lens will glue with the cartridge is lower if you use an OVD instead of BSS. And after that, the lens will go very easily. What I do normally is I start the injection very slowly, and once the lens is almost inside the eye, at the end, I don't do a continuous pushing.
You release
just
a bit.
lay back and do like 2 or 3 small pushing, and like this, the lens will go, and the foam at the injector will never come into the eye. And like this, I haven't had any problem in hundreds of patients implanted, either with ISOPURE or with MicroPure also.
Okay.
But you have to be thorough regarding this.
Thank you. Another question, tricky question, and don't speak against my friends from Alcon or Johnson & Johnson. So what would be your fair opinion, advantages between ISOPURE in comparison with IANS or with VT from Alcon?
We have experience with both lenses, with VVT and IHANS. Personally, I have experience, not as large experience with VVT and IHANS. IHANS is a lens that works, and the results are very similar to ISOPURE lenses. But in my experience, larger pupil patients do better with ISOPURE, and this is something that has to do with the optical design of the lens. There is a paper published by the group of Nuria Garzón, I think it's a GSCRS at the end of last year, evaluating in an optical bench how IHANS works, and over 3 millimeters of pupil diameter, basically the lens works like a monofocal lens. So the advantage is much better with the smaller pupils. In the smaller than 3 millimeters pupils, I don't think there's a great difference between IHANS and ISOPURE. And regarding VVT, pros and cons. Patients who work very well with ISOPURE get better near and intermediate vision. But there is something that I don't like very much with VVT, and this is the lack of homogeneity in patients' results. VVT has an Axicon, which is a conic lens in the center of the lens, and this makes that the results, the outcomes, the clinical results of the lens are very dependent on the pupil size and situation regarding this Axicon in each eye. So if the lens is properly centered, then the result is going to be good. But I have seen patients who are unhappy, who have more dysphotopic phenomena that with IHANS or ISOPURE. And this is something I don't like very much. I prefer to offer for my patients, in which I decide to implant this EDOF monofocal lens, a bit less of glasses independence, but a safer vision quality profile. And this is something that is completely related to the optical design of Eyhance and ISOPURE and VVT or Lucidis, for example, which are lenses that offer probably in big numbers better intermediate and near vision than ISOPURE and Eyhance, but a bit less unpredictable results, and some patients unhappy, sometimes with the distance vision, sometimes with dysphotopic phenomena.
Okay, excellent, thank you. Next question, in case of refractive surprises, could this lens be combined with a piggyback sulcus lens?
I haven't done it. I would prefer, if I can, do it
touch-up.
Do it a laser touch-up. Yes, but I don't see why not.
Okay.
I think refractive surprises, if possibly treated but with corneal laser, are better treated and is much easier. In my practice, I can do it. Yes.
Okay, thank you. Next question, is the aperture independence of ISOPURE versus Eyhance a big advantage in your practice?
Can you?
So is the aperture independence of ISOPURE versus Eyhance a big advantage?
You mean the aperture, the optic size?
Yes.
The size of the optic.
Yeah.
Yes, definitely. This is what I'm telling you. In my experience, it's an important issue. This is something that we are going to study thoroughly in the clinic, and we are going to hopefully do a prospective comparative study between these two lenses that are similar in their optical design, but not completely equally. And hopefully in a few months we'll be able to answer more precisely this question.
Okay, thank you. So I don't read or I don't see any additional questions. So I will stay there for 1 minute. And if we don't have additional question, I propose to finish this webinar. So just for my information, can you share a bit with us the numbers of ISOPURE that you implanted since you started in September 19, more or less? Do you have an idea on?
Yes, 150 lenses, yes.
Okay.
Around 150, yes.
Okay, and do you have already some data on PCO, because you mentioned it during the presentation?
No, we have PCO rates low regarding the micropure. I think I have done 1 or 2 cases laser YAG after months, but these patients were patients with dense posterior capsule cataract, and that couldn't be completely clean during the surgery. So these patients went out from the theater with some remnants in their optical, in their posterior capsule that were left unpolished because it was literally impossible to do it. And I perform a YAG capsulotomy 4 or 6 months after the surgery. This is the time I usually wait to do it.
All right, so I don't see any additional questions, so I propose to close this webinar. So Dr. Bilbao, thanks a lot for this talk and the time you spent on, and thanks to the attendees, sorry. So have a good evening, and we see each other really soon. Thank you very much.
Thank you very much to all of you. Thank you for your patience.
Thank you, bye.
Bye-bye.